I'm going to introduce you to our two guest speakers this afternoon. I have with me Dr. Linsey Steege. Steege, thank you. And Linsey Steege is an assistant professor at the School of Nursing here, and she's also has an appointment in industrial and systems engineering. So we're getting into our interdisciplinary conversations here, and this is I'm so happy this happened today because we talked about a lot of the things that can go wrong with interprofessional teams, but this is going to be some examples of some great work with interprofessional work. Her background is in human factors engineering, and her research program aims to improve the safety of providers and performance and overall quality of care. So it's important to think about the patients, and we've talked a lot about being patient-centered, but who's right next to the patient at the point of care is that provider. So by making sure the provider's work is safe and healthy and sustainable, you can do a lot for quality. We think of sometimes we talk about the provider as the internal client, someone that we also have to take care of if we're leaders within the system. And then with her will be Dr. Barb King, and she's an assistant professor at UW-Madison School of Nursing. And her research looks at functional decline and the loss of independent ambulation in older adults. So how many of you have faced trying to help patients get moving and walking after a procedure or at a certain stage in their life? Just about everybody. So I think, and even after birth, right? So I think a lot of it, what they'll talk about is really one of these cross-cutting issues that touches everyone. So she thinks about during hospitalization and also transitions from care to hospital to a nursing home setting or some kind of a home setting. I know many of you probably don't have extensive nursing home care the way we do here, but when people are going back to a setting where they're going to need a caretaker, they're not going to be independent, that's kind of similar. So with that, please feel free to add anything you'd like the group to know about you, and thank you for being here.
Okay, well, thank you for having us. I, again, am Linsey Steege, and Barb and I are going to be with you for the next hour and a half or so. We both, I think, talk somewhat fast, so we're also fairly informal. Please stop us, ask questions. We're happy to digress a little bit. We've got slides, but we would love to have this be as conversational as makes sense. So we are going to talk about a project that we've been working on that is an interdisciplinary effort trying to improve quality related to ambulation and patient outcomes. But first we're going to talk a little bit about sort of the different backgrounds and perspectives that we bring to that. So we have this structured roughly as a little bit of backgrounds on human factors engineering and systems thinking, which is my background and expertise. Then some stuff on patient ambulation and more generally why this is an important issue for quality. Got a little breakout session so you don't have to listen to us completely for an hour and a half. And then we will talk about the specific project that we have put together called Movin' and have time for questions throughout. So we identified some objectives that hopefully through the presentation but also just having access to these materials and readings, that having some understanding, at least exposure to human factors as a tool or as a discipline that intersects with quality improvement quite a bit, and then recognizing the importance of patient ambulation as a quality issue, identifying opportunities in your own work, in your own institutions, your own organizations for utilizing these tools, and then just again an example of an interdisciplinary team and how we are working on quality. So we have just a couple slides here to sort of reiterate our background. This is mine. I am not a healthcare clinician of any sort. My background is entirely in engineering. So my undergraduate degrees were in biomedical engineering and computer science. Then I worked for a few years at a hospital in Washington, D.C., doing research primarily, and then got my graduate degrees in industrial engineering with a focus on human factors, which we'll talk a little bit more about. And then again, there's sort of a reiteration of my research program, and I tend to study the workers in the system. That's my industrial engineering perspective. So I do a lot of work on nurses and understanding nurse fatigue, nurse stress, nurse workflow, and how to design the system to better support nurses. And then through that should hopefully translate to improved patient outcomes as well as organizational outcomes. So, an engineer. So just, is anybody in here an engineer by chance? All right, well there's at least one other person that's, so again, stop me if there's questions or if something is not clear. And Barb?
So I am a nurse. I have an extensive background in clinical practice. So I have worked in acute care settings for longer than I hate to admit at this point. I'm also a geriatric nurse practitioner with my master's degree. So I saw patients a lot out in my outpatient clinic, and I would see them come to see me on a follow-up after they'd been in the hospital, and I'd be going, oh, jeez, what'd they do to you in that system? Because they couldn't walk, they couldn't do their ADLs, their medications were all messed up, nobody knew what was going on with when they had to come back for appointments. And, it was very frustrating for me as a practitioner to try to figure out how do we safely transition people, and then how do we keep people in their homes? Because typically what we ended up seeing and failing in place, and then having to do nursing home admissions because they were failing coming out of the hospital. So I went back and got my PhD and graduated in 2010, and my focus was really trying to look at what did I see as a clinician, and what I saw as a clinician is people were fine in their function going into the hospital, and they came out and they couldn't bathe themselves, they couldn't dress, they couldn't climb upstairs, they couldn't walk, they were falling down, medications were all messed up. So I really started getting interested in this whole issue of function. And so my PhD dissertation was all about, well, how do nurses think about mobility in hospital settings? And that really helped form the basis of the project that Linsey and I worked on, created together. So I'm all geriatrics. I'm all about the old people. It's my area. And I will tell you, though, that my brother-in-law, who's not geriatrics, recently got admitted to a local hospital. And the first thing he said to me is, I totally get what you talk about now with mobility, because I have been strapped to this bed, and I won't leave my room because I'm afraid I'm going to miss the rounding team. So I won't get my walks in because I don't want to miss these opportunities to connect, so makes me start thinking about this whole issue of systems and why do we have these quality problems within our systems. So I'm all about let's make this better for older adults so we actually don't make them sicker, and they are less likely to have increased healthcare utilization because of problems that we sometimes create in our systems. So my issue with healthcare and human factors was really working with Linsey and looking at, so I've got this model and I see these things, I know the barriers, and I've been reading SEIPS, and let's talk about how we can build a structure that might get at some of the systems issues. So my program of research is all about designing sustainable and scalable practice change to improve outcomes for hospitalized older adults, whether that be ambulation, whether that be delirium, whether that be transitioning care. I always want to think about what is it within these systems that affect nurses and their ability to provide care that in the best way that they possibly can to improve these outcomes. So I look a lot at what are all these barriers that get in the way in their work system that prevent them from doing the right things that they know they want to do for their patients, and then how do we design models that actually can be used. And the reason why it's important for me that they actually can be used is because I'm a clinician. So there's nothing more frustrating as a clinician when somebody comes in and says, just do this. And as a clinician, well, okay, that's nice. However, there's all these things that get in the way for us to just be able to do this. So I try to think about how do we make this very practical and very pragmatic to get beyond barriers that we can start implementing these very innovative and creative ways to do practice change.
Okay, so now you know who's up here talking at you a little bit more. And we're going to start with talking a little bit about human factors, because that was sort of a theoretical foundation for a lot of what we've done. Have people heard of human factors or ergonomics as terms? Some familiarity, some not so much. I'm going to do the overview here of kind of the redefining what is this, what do I mean. So human factors is it's a discipline. It's become sort of a specialty area, commonly across the world, actually, either in a psychology type of program or in an industrial or an engineering, systems engineering program. And some people like to say that human factors essentially steals from a lot of other disciplines, psychology being one, biology, anthropology, biomechanics being some others. And we kind of put that all together and apply it towards designing systems. So whether it be the chairs that you're sitting in, the desks, the environment, technology, how people work together in teams, so that they're safe, hopefully as easy to use as possible, so that enables humans to perform well, and then ideally also satisfying so that people don't hate them. So everything around you could be exposed or dealt with through human factors design. So in order to do that, you have to first understand the sort of capabilities of people. So what are their physical, mental, psychosocial limitations, abilities? So understanding anthropometry, understanding mechanics of if you sit in a certain way, what's that going to do to your low back? If you lift something, what's that going to do? And then cognitive processing. So how do we take in information? How does memory work? What are mental models? So kind of runs the spectrum from more physically oriented things, cognitive, and then sort of interpersonal issues have kind of come under organizational human factors. Once we understand and can analyze the people themselves, then we try to translate that into how to design to fit those needs. So that's essentially the discipline in a nutshell. So people will sometimes focus one way or the other, but the whole goal is to try to design for people. And then understand how the person interacts with everything else happening in the system. So very much the human is the center. So another way to think about this is we're optimizing the relationship between the human and the system, and again, trying to fit everything to the person where possible versus having the expectation that people will adapt. So the idea of training, which is often a tool that's used in, we want to improve quality, or we see that we have this deficit or this gap in where we'd like to be and where we are, let's just train people. That is a strategy, it can be used, but training is asking the person to change. So we also, as a human factors lens, want to look and see what else in the system should we be changing, because we can't just constantly be expecting that training will solve everything. And that's where we look for barriers, facilitators, places where the system is a mismatch. So we can train you all day, and then if you go back in and the system is broken and it doesn't match up with the training or this idealistic view, you'll resort right back to what you were doing before, and it's not your fault. It's the design of the system. So some of the examples I like to give that we encounter a lot, even in this beautiful brand new building that we love so much. We're both in the School of Nursing, so this is our home building. Doors. This is a simple example, but if there has to be a sign on a door telling you whether or not you should push it or pull it, that's not a great design. There are a lot of doors that you walk through without a problem, and then there's that door that you're walking along and you run up and you feel stupid because you're like, oh God, did anybody just see that? I don't even know how to open a door. It's not you. The door is poorly designed, and so the system around you is failing. If we have to put a label for a door, something is wrong with the door. Okay? So oftentimes people do this because it looks pretty, and it's all glass, it's an aesthetic appeal, but functionally this doesn't serve people very well. So you'll see if you scale this up, there are a lot of things that are not designed well. So if you're feeling frustrated with the technology, if you're feeling frustrated like, I must just be an idiot, I'm not going to say 100% of the time, but most of the time we could trace that back to some design issues that could be improved. So there's no such thing in a human factors perspective as having this perfect employee that will just mold and fit exactly what you want them to do. You have to understand them, their needs, and then design accordingly versus expecting that everybody coming in will adhere to your protocol, follow your training, etc. So that's kind of human factors as a discipline. And where does this intersect with quality? So to me, this is just natural. It weaves together. I tried to sort of tease out some of the areas where I think it's more explicit. If we're thinking about quality in complex systems like healthcare, generally these systems do rely on human performance at some point. So the idea of human error being a potential source of quality problems, or that humans performing consistently or in a standardized way is going to be important for you to achieve whatever quality outcome, then you're dealing with human factors, because you need to address design for that human in order to expect that they will hopefully perform to the best of their ability. And then I don't know if you guys have had exposure already or through your own careers to the different sort of human error philosophies that are out there. There's been a sort of long-standing culture in many healthcare systems that there's this person who made an error at the end, and it's their fault, and sort of the blame gets pushed to, let's do more training, let's punish that person. They were the last one that touched this medication that went into the patient. That was a wrong medication, therefore they're it. And then now there's much more of an understanding and hopefully growing culture that there's much more to it. We have deeper system issues. We have the idea of sort of the blunt end of care, so everything that happened before that last person, which is often a nurse, was touching the patient and had the opportunity to make that error. So we try to think about all of the chains of things that happened before that that led to that being even possible. And in other scenarios, not in healthcare, we often will, in human factors, try to design so that you can't make an error. So in a lot of like automobiles, you can't insert your key the wrong way. It either goes both ways or it doesn't go the wrong way. So you can't jam it and cause a problem. That's been designed out of the system. So we try to design out opportunities for people to make a mistake. Has anybody heard of the Swiss cheese model of error? A few people nodding. So again, this is a similar idea that there's multiple layers of defense for quality or for error and safety in a system. And when we see patient harm or any sort of error that might occur, we have to look and see where were all the holes that lined up in the system that led to that being possible. So if we line up pieces of cheese and all the holes line up, then an error can propagate all the way through the system. And I think I have a little bit of a bigger picture here. So the ultimate error for this one is a nurse gave a patient a drug which they were allergic to. And so oftentimes people will say, oh, medication error, nurse made a mistake, what's wrong, punish the nurse, train the nurse might have been tired, they may have been. But there were several things that happened before that, so the pharmacist didn't check for the allergy, the prescriber ordered the medication which the patient was allergic to, and way back someone didn't obtain a full history and have that allergy information in the record or available clearly to everyone. So again, we try to look for these root causes. I'm sure you guys have heard about asking why, like a million times. So that's the same idea within human factors. It's just we're asking why, but thinking that the person being just a horrible person that likes to make mistakes is not usually an answer that we will accept, at least right away. Those people do exist, but for the most part, that's not the case. So we need a systems perspective to sort of intersect with this to understand how this all might fit together. So in human factors engineering, there are a number of different models that we'll use to look at a broader system. One of the ones that's most common in healthcare systems is called the SEIPS model, or Systems Engineering Initiative for Patient Safety. And I think we had a reading related to this that we disseminated. If you didn't get a chance to look at it, it's a great reading. It explains the entire model. I'm going to try to give the brief version here this afternoon. But has anybody seen this model before coming today? A couple people. Have people heard of the Donabedian's model of structure, process, and outcome for quality improvement? A couple. Okay, so this model is based on the Donabedian model. So it thinks about, when we're thinking about quality, when we're thinking about a system, we can think about the structure of the system, the processes that people are, or the system is trying to accomplish, and then the outcomes. And so that's loosely what we have presented here. And so on the far left, what this does is takes the idea of structure and goes a little bit further and makes this more explicit. So we think about a work system, and there are different components that are at play in any system. So here, the person is in the middle. Human factors engineering, we're all about people. They are the focus. So they're in the center of this work system. And a person can be a patient, It could be a provider. It could be a team of people. It's represented as one person here, but it's really any people that you might care about in this work system. And when we're looking at this, we're interested in understanding, okay, what are the attributes about that person that might be relevant for the processes and the outcomes and the context that I'm interested in. So if you have a quality improvement project, you might take this and say, okay, who are the stakeholders is another way of thinking of this. Who are the people that are involved in this process that you might be improving? What's their knowledge? What are their biases that they already have? How do they think this process works or should work? So some of those human attributes, what's their experience with this? Prior education, do they have experience working together? Those elements would fall under this person domain. Then we have technology and tools. So what are the technologies that are available? What types of tools, checklists, guidelines? It doesn't have to be computer-based to count as a technology or a tool. Bottom left here, what are the tasks that these people are trying to accomplish? So this is a little bit different from a process, but what are the order of sort of the priorities that they have? So if it's a nurse, the sort of nursing process. So what I'm doing an assessment task. I'm doing taking vital signs as a task. I'm doing entering data into the chart as a task. And those all serve a purpose for a bigger process, but what are those sort of individual steps or tasks that we can break that down into? Oftentimes in tasks, we'll also think about like time pressure. How many tasks is someone being asked to do at once? Are they being interrupted during those tasks? Does the order make sense? Then we have the physical or built environment. So in this building that you all are in right now, we paid a lot of attention. Our goal was for people to be able to learn and engage. And so there was a lot of emphasis on trying to design this building to promote learning so that you can flip around at the tables and we don't have as many traditional lecture style rooms. So we thought about the physical environment and how that might facilitate learning or act as a barrier. And then there's the organization. So how are people organized in teams? What's the schedule of their work? What's the culture, the climate? What are some of the potential organizational priorities that might influence people? And all of these things together form the context or the system, the structure. And they're all interrelated. So if you change one thing, that's going to impact everything else. That's systems theory, which I hope many of you, it's a lot of common sense. It makes sense. If I change one thing, something else is going to change. I'm going to talk about the rest of the model for a second, and then I'm going to come back to one of the other key pieces of the system. So the whole structure is working together. We're carrying out different types of processes. In this original SEIPS model, we're thinking about care processes and then other processes. So it kind of divides care and everything else that happens in healthcare that may not be directly related to patient care. And then we think about different outcomes that we might be trying to achieve. So there's the patient outcomes. So patient safety is a huge emphasis. It's in the name of the model. And then quality of care in other ways that you might assess that. So patient-centeredness, actual sort of measurable clinical indicators could all be considered patient outcomes. And then we also think about employee and organizational outcomes as well. So from my perspective, I care a lot about what's happening to a nurse provider at the center of this. If being exposed to this system and carrying out these processes is resulting in nurses being injured or very fatigued or very stressed, those are all nursing outcomes that are concerning for me that might lead to turnover and other retention issues. And then organizational outcomes like efficiency, cost, again, quality at an organizational level. So this is the model, and essentially this is a framework for us. It helps us when you're thinking about other quality improvement tools like a root cause analysis, and you're trying to tease out what are all the potential contributing causes. Have you guys talked about like fishbone diagrams or those? So a lot of these structural elements align with things that might be one of the bones on a fishbone. This is just another way of representing it and helping us to sort of think through did we think about how technology might be playing in here? Did we think about the physical environment? When we're thinking about potential solutions, so once we've got past root causes and we're now trying to design an intervention, are we proposing something that when we put it into place, like a lot of at our hospital across the street, there are a lot of solutions where we want to put some new technology into a patient room to make it bedside so everybody can access it more easily, we can have better communication, but there isn't space. Physically, it is not possible to put something else in many of our patient rooms. So that solution doesn't really make sense. We're going to encounter problems in the long run if we try to implement that. So again, a structure to help you think through causes and then also the potential impacts of an intervention or a solution that you might try to implement. The other thing that this model is used for very commonly, which we'll come back to when we talk more about our project, is thinking about when you're trying to understand a problem and really the broader context that that problem is occurring in, what are the barriers and facilitators in each of these areas? So really, again, understanding contributing causes to some sort of gap in quality that you might be trying to address, and how does the environment act as a facilitator to making that better or potentially a barrier? And then from that, we can use what we call balance theory. So sometimes there's things in here that we can't change, like often the physical environment that requires a pretty big investment to build a new building or remodel. So we can balance that out by trying to emphasize other components of the system that might facilitate and may be able to overcome. So those are some of the theories that human factors and systems engineering tries to use when we think about quality improvement and the process that you're all going through. This is just another tool that we bring to it. So I'm going to stop and let Barb talk a little bit more about our specific context here of older adults.
So this will help you think about why do I get so crazy about making sure patients get walking, and really is the whole basis for what we came up with our model, which is called Move In. So I'll just familiarize you a little bit with the terminology because I live in this land all the time. So if I say a term you don't understand it, say, what do you mean? So there's this term that's been out now in the literature for the last probably close to 10 years, and it's called hospital-associated disability. So what that means is that a person goes into the hospital and they're completely functionally independent. They can bathe themselves, dress themselves, feed themselves, they can groom themselves, they can toilet themselves, they can transfer, and they can walk. And they leave the hospital with a disability now in one or more of those basic activities of daily living. The older literature on hospitalized older adults talked a lot about functional decline. And that literature only measured those basic 6 ADLs and didn't look at mobility. So hospital-associated disability ramps it up another level to saying, well, wait a minute, what if they can't walk? This would be a little bit of a problem, right, if we send them home. So there was a big gap in the original literature on functional decline because they didn't at all look at a person's ability to walk. So this brings it up another level. So if we just look at a person's ability to do basic ADLs, bathe, dress, feed, toilet, groom, transferring, we see a 30 to 50% incidence of functional decline in one or more of those ADLs because of the hospital stay in general in older adults. If we add on top of that now walking, and that means an older adult comes in and they're able to walk with or without assistance across a small room, 59% of them will now become dependent on somebody else to walk across a small room. So they came in able to walk, they leave, and now they can't walk. So if you think about that from now they're going to go home, what kind of resources do you have in your area to help somebody who can't walk? You know, we send them to nursing homes. That's our answer. We'll just do some rehab for a while. Or we send them home with the 89-year-old caregiver who might also have dementia and have some problems walking. And we think that that's the solution. But we have a problem from a quality standpoint if that's the way we think we need to manage this issue. So the hospital environment's not so nice for older patients in the United States. It's not that we do bad care. We do great care. It's a problem with what we do within our environment. So our care is all centered on the bed. Patient comes in, they get admitted to a bed. They stay in that bed until they get discharged. We don't encourage them to get up. We don't let them do their own ADLs because it's faster if we just do it for them. We do hourly rounds, and hourly rounds mean we contain patients. We make sure your phone is right here, your water's right here, your call light's right here. I'm going to check on you every hour to make sure you have to go to the bathroom. So you just stay in that chair or stay in that bed. We contain them. And a lot of that has to do with we don't want them to fall. So we contain patients. When we contain patients for an older adult, it's hostile. They lose function rapidly when we contain them. We have high beds, we put side rails up, and we tether them. Sometimes we have to tether them with IVs or oxygen tubing. So we don't think, well, they only have antibiotics running twice a day. So maybe we don't need to tether them twice a day. Maybe we can take the IV, disconnect the tubing so they can get up and move around during the day and reconnect it when they need their antibiotics. So we have to think more logically about how do we not tether our patients. It's confusing. It's congested. When I did my observation studies, I looked at ambulation, of what nurses were doing engaging patients in ambulation, and between 7 and 10 o'clock in the morning, I was standing out in the hallway watching this massive movement of white coats coming down the hallway with computers. And I thought, why would an older adult come out in this hallway between 7 and 10 o'clock? First of all, there's no room in that hallway for someone to walk. And it's a confusing environment. It's loud, it's noisy, they don't have their glasses on, they don't have their hearing aids in. It becomes a threatening environment for them. So it's hostile. So we have to rethink about our environments. Our environments, do they really support mobility? Actually, they don't. This is really expensive in the United States. So in the U.S., new disabilities that occur because of hospitalization cost us $26 billion a year. And it's because of nursing home placements and the need for rehab and the need for home care services and now the need for additional physical therapy once they get home. $26 billion. And a lot of it has to look at what do we do within our systems that's causing the increase in healthcare utilizations. Now, people used to say to me, well, you know, Barb, once they go home, they'll get better. Well, the literature says they don't get better. So we have now data that says 30% of older adults, if they develop a new disability, in 3 months will still have that new disability. They won't get it back. Even more recent data is now saying 55% of those individuals who develop a new onset disability because of hospitalization in 5 years will still have that disability. They don't get better. So now they are disabled, which is going to drive increased healthcare utilization costs. The most preventable and predictable cause of a hospital-associated disability is bed rest or limited movement. It's been proven over and over and over again. We don't move people, they start to decline, specifically this population. So what an easy thing to fix, but it's really complicated to get patients walking in hospitals, and that has to do with the model that we designed. So people say to me, really? Do they really not walk that often? They really don't walk that often. So we've done accelerometer studies here in the United States. Steve Fisher is from the University of Texas, and he hooked accelerometers on patients. And he wanted to see, so how much do they walk? 96% of patients are not engaged in any ambulation during their hospital stay. And if they do engage in ambulation, it's 18% of what they normally would do if they were in the community. 18% of what they normally would walk. Cynthia Brown from the University of Alabama, Birmingham, has also done accelerometer studies, and she found that 86% of the time patients spend lying in bed during their hospital stay. If they're not in bed, we might get them up to standing or in a chair, but that low mobility still causes insults to the musculoskeletal system. So they still get decline. So then we did observational studies. Our colleague Jane Mahoney here at the University of Madison, she was the first one to look at, so what is going on in the hallway? So we'll just observe patients walking in the hallway. So they didn't look at anything that was going on in the rooms, just hallways. And what she found is that about 73% of the time during their observation period, and they did 3-hour segments, and they covered a 24-hour period doing these 3-hour chunks of time. So during any 3-hour period of time, 73% of patients who could walk never got out in the hallway and walked. So then she started looking at, well, who are they walking with? And only 9% of the time did they ever walk with a nurse. Who has the most contact with patients? Nurses. Who was not walking patients? Is it because they're bad people? They are not bad people. No. They are good people that want to do good things. It's a system issue. So we had to think about how do we move the system. So then we did an observation study. So I'm thinking, well, okay, so we're just not capturing all of these other levels of mobility that are going on in a patient's room. We need to capture that. So we shadowed 15 nurses, and we shadowed each nurse for 24 hours, 3 8-hour shifts. And so you can do the math. We had over 300 hours of observation. So we wanted to look at, all right, so what are they doing in thinking about all the different ways you can be mobile? Can you stand at the bedside? Can you transfer to a chair? Can you walk in the room? Can you walk to the bathroom, from the bathroom? Can you walk out in the hallway? So we look at 6 levels of mobility, and nurses think that way. It's a progressive way of thinking about ambulation. And we had 47 patients consent for us to look at their electronic medical record to gather characteristics about them. So what we found in those 47 patients is that 32% of them had no mobility during their observation period. No standing, no transferring, no walking in the room, no walking to and from the bathroom, no walking out in the hallway. That's a pretty high percentage of not moving at all. So then we thought, all right, so let's look at the breakdown of these different mobility levels. And so we found that actually with the engaged nurses, mostly engaged patients in is standing and transferring. But because we have all of these zeros in here, the means of standing was 0.7. The mean of transferring was 0.5. So it's just not happening. Actually, patients initiate ambulation more than nurses initiate ambulation. But even the mean duration when we ambulate patients is 1.8 minutes. So it was less than 2 minutes during an observation period. So not happening, and when it does happen, doesn't happen very much. So it's a problem. So then we're thinking, okay, is it just us? We got a bad system. What's the problem? So Kalish actually did a study, and she surveyed 3,000 nurses and 900 certified nursing assistants. And she was really interested in missed nursing care that was occurring in hospitals. You know what she found? Is that 80% of nurses report that walking patients is the most frequently missed nursing care. So we have an order. We know it should get done. It doesn't get done. And of that, 33% of nurses say they always miss patient ambulation. So it doesn't happen. Now, it's not just us. We know that other countries are experiencing the same kind of phenomenon. We just not walk patients. So why is this bad? Well, for an older adult, this is really bad. So this is an article by Creditor, and I think I referenced it on your reference sheet up on these slides. So it's a great Sentinel article. Highly recommend if you're talking to anybody about ambulation. This was the first one that came out and said, oh my gosh, we've got physiologic evidence on what is so bad about not moving patients. So the top of this little body is saying this is what we normally know in aging. Okay, we lose muscle mass and strength. We have more likely to drop our blood pressure, so there's vasomotor instability. Our bones get thinner. We don't ventilate our bases very well, so there's a decrease in ventilation in our lungs. We have alteration in thirst. We don't know we're thirsty, so we don't drink. And our skin gets fragile, so there's more likely to have pressure ulcers that will happen. And although it's not normal aging to have urinary incontinence, we see it more likely in older adults that they develop incontinence. So now we're going to put you on bed rest, and we're not going to let you move. And here's all of the nasty things that happen when we put people on bed rest. The most likely what you see in plasma volume is you get a 600 milliliter loss of fluid plasma in your central circulation. So what does that equate to? It means people get orthostatic hypotension, so they stand up, and what's the first thing they say? I'm dizzy. What's the first thing we do? Send them back down or lay back in bed. You're dizzy. I'm not going to let you move. Well, it's actually this 48-hour period of time that they lose this volume, and if we would just start moving people, they're less likely to have that happen. So we got to move people. So putting them back in bed is the wrong thing to do. Helping them set up and gradually adjust this vasomotor stability is the right thing to do. The biggest hit is muscles. So people will lose up to 5% of their muscle mass and strength per day of bed rest. So 1 day of bed rest is 3 days of rehab for a geriatric patient. So when you think about utilization, if somebody is in the hospital for 5 days, that is 15 days of rehab if we have not moved them. Okay, so the muscles that take the hit are the hips and the lower extremities. Why do people fall? Because they have weakness in their hips and their lower extremities. So what we're doing is actually increasing their risk for falling down by keeping them in bed. They don't ventilate very well. they get delirium, they get confused. We're most likely not going to get them up now because they're delirious, and nobody wants to move an agitated patient, which actually you should be doing is moving an agitated patient. So the bottom line is that people end up going to nursing homes because of what we are doing in the hospital. So we have to think about our system. So a lot of people say to me, "Wow, should we be moving older adults?" And I'm like, "Really? Yeah, you're going to question me?" Yeah.
So I have a question.
Yeah.
Isn't this just habit coming back from the old sort of, Florence Nightingale or whatever?
Yeah.
And so it's a matter then of changing habits.
Yeah.
The thought is people are just saying they should be in bed.
It's we thought. People are sick, they should just be in bed. So keep them in bed and keep them at rest. We've actually shown with these early ambulation studies that they actually do better. Lower mortality rates, decreased length of stay, less likely to be readmitted, less likely to have ventilation and pressure ulcers.
So how do you change our attitude? Because our attitude is one that we can function and move around.
Yeah.
And when they get up, they bother us because they're going to get in the way of their own, care.
I know.
Things, and they're going to serve our arms, and we won't make it back to the clinic. Those patients, you know what I mean?
Yeah, I do.
When they're in bed, because we can do
They're contained. You can get to them. So, I was just talking to my brother-in-law, and I said, why don't we give people buzzers? So go walk. We'll alert you. Come back. We got somebody that's rounding on you. We know you're going to be. We need you back here in 10 minutes. You hit that buzzer. It starts buzzing. You need to be making your way back to your room. So there's ways that we could think of it from a system standpoint so that we can have this. So what we did with Move-In, and you'll see that, is we got an ambulation aid. We didn't start that person until 9 o'clock because there's no opportunity between 7 and 9 because rounds are happening, meds need to be passed, physicians want to see their patients, nurses need to do assessments. There's no opportunity. So we can chunk things, and we can think about that from a system standpoint. How do we do that so that we get these patients moving so we have better health outcomes? Rather than, I need you to be contained for this period of time. So it's a systems, it's a way I think we have to think differently about care provision and how can we organize our system to make sure these things happen.
Just make a comment. So I direct a nursing home for 35 years on the default medical board.
Yeah.
Years ago,
Bless you. Bless you.
So years ago, the dad said we have to stop strapping people to the bed in the wheelchair because we were strapping in the beds in the wheelchair and putting up all the encumbrances because we were afraid they were going to fall out of the chair and out of the big fall and hurt themselves. But the Fed said we had to do it, so we had to design other ways of doing it. So in our nursing home, for the people who are falling out of bed frequently, we put the mattress on the floor.
Yeah.
So when they just toppled on it, that turned out to be a very easy solution.
Less likely to injure
The ones in
themselves.
the wheelchair, some of them do fall out, but most of them do not fall out. It turns out more or less they're being out when they have toileting and other issues. So we didn't over a 5-year period, we did not see an increase in hip fractures.
No.
At all in serious stuff, but we had to change our attitude, and now we would never think of this.
Oh, yeah. And even in hospitals, we're really, really moving toward, it's got to be really bad before you ever even think of putting a restraint on somebody. So, and I think part of this is an attitude issue. And, we've looked at the literature on attitudes. So attitudes that nurses have about older adults, a lot of them don't have the background or the education of what do we know about aging and care for this population that is now blossoming here in the United States. We have more and more and more, and we really have not adequately prepared our physicians or nurses, or we have therapists in thinking about what are the acute care needs of this population, and how do we provide care to them. And so we found from the attitude standpoint, sometimes nurses don't want to take care of geriatric patients. They're time-consuming. They're not as glamorous. They have all these ADL needs. They ask me a lot of questions. They're on the call light. They're incontinent, blah, 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 blah. But if we can start working at picking away at those attitudes and we start saying, do you know if you actually engage them in their activities of daily living and have them do the work, they're less likely to be causing you more work because now they can do it. So we started shifting some of our different strategies to get people to think differently about what are their care needs, and actually if we engage them, this is going to be less care that you'll have to provide. So, but it's breaking down those walls, and that's one of the barriers that we had to deal with, was how do we get people to think about mobility differently than how they were thinking about mobility.
That would be the person in the seat.
That person.
Yep. We do have to help them adjust their
we
mental
do.
model a little bit.
We do. And, we think about social cognitive theory and how does that all feed in with attitudes and beliefs and, all these different ways for us to think differently. So there has been lots of research that said it is safe and feasible to move older adults. We got to move all the older adults because of the impact that we're seeing from a healthcare utilization. So this was a study that was done by Mundy. It was done in 2003, and they looked at older adults with community-acquired pneumonia. And so, like 458 patients came in, and they wanted to get them moving. So how they defined early mobilization is 24 hours at admission. You need to get them moving. They got to be walking. So that was early mobilization. What did they find? They found a decrease in length of stay by 2.6 days, getting patients walking. It's huge. They had a decrease in mortality, and they had no adverse events. They didn't have falls. They didn't have people desatting. They didn't have these negative, all these nasty things that we're afraid of by getting patients walking. So then Camel came along, and he looked at these surgical patients, these hip fracture patients. And this was back in 2003, and they actually did a retrospective chart review, and they went back and they said, all right, so what is time to ambulation? And how does that relate to pressure ulcers, deliriums, pneumonias, urinary tract infections? And so what they found from that literature is actually it is directly related. So the longer you keep somebody in bed, the more likely they will get delirious, and the more likely they're going to have an increased length of stay by 98% compared to people that they were moving on post-op day one. So in this population, which are primarily geriatric patients, faster movement equated to better outcomes. So then we have the intensive care unit. So there's this big push right now in ICUs by getting mechanical ventilated patients moving for a couple of reasons. You get them off the vent quicker, and you get them out of the ICU quicker. And those are the outcomes that have been shown. So one of our students, Anna Krupp, is starting to look at, so how do nurses cognitively think about mobility in ICUs, and how can we help them thinking from a cognitive engineering standpoint about decisions they make with ambulating patients. So what this group found, less than 1% had an activity-related adverse event, meaning falls to the knee without injury, feeding tube got removed, systolic blood pressure jumped, diastolic jumped. They desatted to 80%. You know what they found? Nobody extubated themselves. So they're walking around with these endotracheal tubes hooked to a ventilator, and they're pulling the ventilator with. Nobody extubated themselves. They actually found a decrease in ICU stay and a decrease in the time they need to be on ventilators. There was another study that looked at the same phenomenon. Let's get these mechanical ventilator patients up. They're moving. They got out to the floor. What do you think happened? They don't walk. They downslided. Length of stay jumped. Functional decline decreased. So again, we're doing great efforts in our ICUs. If we can get ICU patients moving, we should be able to get patients out on the floor moving. But it's a systems issue. Why is that happening? Okay. This costs us a lot of money. So there's a 22% increase in new nursing home placement because of hospital-associated disability. This is one of the big reasons why patients end up having to get placed in nursing homes. There's a tremendous burden on caregivers. If we send them home and they're functionally now dependent, we now have a caregiver that has to provide that type of care in the home. And a lot of times it's an older adult or a family member that's got to figure out how to take time off to help care for mom and dad that are out in the community. Patients are not very happy when they lose their ability to walk. And so we know that patient satisfaction tanks because of this. There is a substantial increase for negative events. Jane Mahoney did a study, and she found a 30% increase in falls post-hospitalization within 2 weeks. So they're not going to fall in the hospital, but they're going to fall going home, and they're coming back in the hospital. Mark Sager found a 30% increase in readmission rate because of loss of function. So bad things happen to these patients if they lose their ability to ambulate. And we also know that the work that's been done with nurses on the ACE units, that when they're not involved and they can't engage and they get frustrated because they know they should get these patients walking and they can't, the system is a barrier. So they can't get patients walking, so they're really not happy with the kind of care they provide. And we found some great evidence with our move-in model on what happens from a satisfaction standpoint with our providers. So.
Okay, so we want to stop talking for a few minutes and let you all, take a break because people can't pay attention for that long. Sustained vigilance, well-known human factors issue, but also give you a chance to try to digest a little bit of this for a few minutes and talk to your colleagues in your groups, your teams. So we had a handout that was included, I think, in your packets. It's meant to just be a guide for some discussion. So thinking about the SEIPS model and human factors, maybe even more generally, what might be valuable of that for quality improvement in your practice or organization. How might you use this? And then what might you be thinking about in terms of quality improvement and ambulation opportunities? Oh, yeah. It has a picture of the SEIPS model. So in the binder, orange section toward the end. And again, this isn't homework, but discussion prompts. And then we'll spend about maybe 15 or so minutes, and then we'll try to come back. And if you guys have comments or thoughts from your discussion, and then we'll tell you a little bit more about our actual intervention to wrap up for the last 20 minutes or so. And we are available for questions. We'll try to mingle around. Sorry, because I mean,
Speed it up, Barb.
I want
Speed
to
it up,
talk
Barb.
about the attitude. I want to be like, well, yeah, the attitude is an issue. I mean, we do have to change that. It's a cultural issue. But then we also see that a lot of nurses recognize that they would like to be doing this for the patients, but the system is a barrier. So even if we get people to acknowledge, like, we should be ambulating,
They know
then
that.
we put them back into the broken system.
And we can point that. I think we can point that really nicely with like.
And then that also segues to the 2 points that we have sort of at the end, which is we also need to think about patient attitudes. Patients themselves can be a barrier. I'm sick, let me just be in my bed. And one of the things that reinforces the attitude that patients should be walking is the false messaging.
Yeah, that's right.
Broader
The quality issue.
Okay. So, anyway, it's just hard to do. Okay. Well, in the interest of time, we're sorry. We know you probably could have a lot of discussion, and you probably are experiencing that on day 2 of this class, wanting to just get a chance to discuss more, probably all the things that you're taking in. Quickly, did anybody have any key insights or questions or ideas on either human factors, the SEIPS model, or did this spark any ideas for ambulation and quality in your organizations? Yeah.
So we had an interesting spark by in our group. We've been talking about C. diff infections, and I was wondering if you knew anything about. We know that readmissions are less with ambulation. Do you know of any specific data looking at recurrent infections in patients that were ambulated more?
Recurrent C. diff infections?
Not necessarily, just
Any
overall
infection.
the body's ability to ward off infections.
So the literature on ambulation hasn't looked at that. So it specifically looked at as falls and function. So it hasn't looked at how likely are they get, pneumonia when they go home, how likely they have urinary tract infections when they go home. A lot of it is saying the thought is what's brewing when they go in the hospital. We don't know it. Now they go home, and then 4 days later, there's the pneumonia. So that has not been looked at specifically, what happens with infections.
But it would be interesting. I mean, you might hypothesize that it would be also just
Well,
overall
it's the issue
healthier.
of atelectasis. So they get atelectasis in the hospital, and they're really not moving very well, and we send them home, and now they aren't really moving very well when we send them home. Maybe we told them you're going to fall, 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 and so then they go, oh my God, I'm going to fall. So we don't know. We just don't know. Does that equate with now they've got pneumonia and they're back because now they have the pneumonia? Although there was some readmission stuff that looked at pneumonias. So isn't pneumonia is one of the 3 areas that we looked at for readmission rates? So heart failure, pneumonias, and I can't think of the other one. So the question I always think about is that, so how much of this was brewing stuff that happened in the hospital, and then we see it when they come home. So, yeah.
Something that we've been working on is infections post-cesarean section surgery. And so what we were talking about in our group was that getting patients up and walking more, like you guys have been talking about, would stimulate the vasculatory system.
Yes.
With greater circulation, you would either probably decrease the incidence of infection and definitely clear infection faster, and maybe control that infection better in an earlier stage. Having a significantly more ambulatory patient.
So,
Potentially.
Yeah, I think along that line has to look at nutritional response. So, I don't know, do people that walk more, do they eat more? I don't know. Is there a better caloric intake? Are they less likely to go into a negative nitrogen balance? So those are all factors that we think about also with infection. So we don't know. A lot of that stuff has not been looked at. We actually don't know how much people should walk. We don't have a dose effect. We don't know if it's 3 times a day, is it 4 times a day, is it 100 feet more than you normally do. We just don't know that. And that's the next piece of what we have to uncover is, well, and it's patient specific. So not everybody, if you have somebody that can only walk 100 feet, you're telling them that, okay, your goal is 500 feet every time you walk before you get out. That's probably unrealistic. So if it's 100 feet, it's 100 feet. And then can we bump them? But what do we have to do in order to bump them, to get them up a little bit more? We don't know. There was one study that was done, and they went from 3 times a day ambulation to 4 times a day, and I believe that they increased distance by 400 feet for patients, which is pretty substantial for some of these geriatric patients to bump them up that much. So that was pretty good. So that's the only one that's been out there that's looked at anything that's dose-related. So the whole infection thing is a great question. We don't know. Yeah.
The thing that would be difficult is coming up with strategies to address this problem. I mean, you've defined the problem very well.
Yeah.
Talking with Dawa, and walk people require more staff. I mean, like you said, the nurses don't like it because it's more work for the nurses. In order to walk people, you're going to have more nurses. And this whole program, this workshop, is aimed at medical facilities, with limited resources, and that includes trained staff.
Yeah.
I mean, I don't have an answer for it. I mean,
So hopefully our model will show you some of the
Okay,
creative
all right.
things that we've done, because those are the things that we kind of battled with. Like, we know what we had from our qualitative research and what the literature shows. So, they're up against a brick wall here. So we got to figure out how can we balance theory. Can I shift that? Does that affect this? Can we shift this? How does that affect that? So we thought very creatively about what did that need to look like from a system standpoint.
There is also evidence in the literature that just adding bodies doesn't necessarily lead to a sustained impact on ambulation. Mm-hmm. So even if we did have unlimited staff resources, there are still other system barriers that were inhibiting the success of those programs, because there have been a few that have tried. Okay, let's throw another couple people in here and see if that impacts. And it does, but it's not as sustaining.
So the minute that person goes away, so does ambulation. So we have to think about very creatively, what is it within this work system? How can we tweak things to produce behavior changes?
Actually, you have to consider where you are in. So if you are in South Asia, then it's quite easy, because we have a joint family, and then and most of them, our culture also is very friendly about that. So patient or even a patient or geriatric patient, they don't like other people to help them. So they like their one family members help them. So that is another factors that can play into this system.
Yeah.
So
more opportunity.
Yes, more opportunity.
We need more creative. So Sharon Inouye did a really nice study called the HELP study. You guys familiar with HELP? Sharon Inouye's model? No. So HELP is great. One of the things that they do is volunteers. So making sure you get water, making sure you're eating. I'm going to chat with you. Less likely to go into delirium. They sleep better, and hey, they're walking. So that would be similar to, do you have family members? What can we do to maximize opportunity within these systems that might be able to shift a balance a little bit? So but it's not just that body. There's lots of other things that we were looking at also, which we can think about, how do we integrate that in these systems.
Do you guys have another comment? And then we'll talk about our model for at least a few minutes.
Mm-hmm.
Yeah, I had one comment that was very similar to that. I mean, majority of the patients that you see, they have at least one visitors during the day. Mm-hmm. I've seen patients walk with their family members that come by. And then also, I think empowering the patients themselves, that information they don't know about it. I didn't know about a lot of this other statistics. The only thing that I was concerned about DVTs, if they sit for too long. But now, sitting in this presentation, I can go back and motivate patients to walk a lot more. Mm-hmm. And not all patients are at high fall risk. The ones that can walk by themselves, they should be encouraged to just, get up and move around.
So our patient level data, patients will sit there unless somebody says, hey, you need to walk. They'll say, right, I would vegetate in this bed. Unless someone told me, you need to get up and move, and you got 3 times a day, and we're going to put boxes on this whiteboard, and you got to check them off. Somebody directs, they're more likely to engage. If somebody doesn't direct, they won't engage. So we have to think about that message, that how do we put the patient with the staff in the center of a model? So there's a lot of creative ways that we can be thinking about, how do we do this?
Yeah, well, we had one more.
Mine is similar like her, and it's not only to train the nurses, but also to educate the patients. Belief system, like many of patients feels like I'm sick and I should be lying down. Low resources, their home is far away from hospitals. If they get discharged early, they might come back in sooner than they feel good. Mm-hmm. Of the times, like in Western medicine, we just treat the investigation. Labs are good now; you are ready to discharge, but patients don't feel good at all. Mm-hmm. That's why they try to lie down more than they're sick.
So we have to think, why are they doing that? So
could be the
could
one.
Could be. So we have to think of all of these things.
Yeah, it's a psychological and
yeah.
Okay, so we're going to just try to spend about 10 minutes, and we're going to go fast because it's hard for us. Through this model, just highlights. We're happy to talk more in the future, emails, questions if you have specific questions, and then we'll try to allow for some time at the end.
So we came up with MOVE-IN, which is mobilizing older adults via a nurse-driven systems intervention. And this was based upon our research, and it was based upon review of the literature to look at what are all those barriers that get in the way. So we found that there's actually a lot of, it's not that easy. Just get the patient up. It's not that easy. So there's barriers internally for each nurse, and then there's barriers within the system. So we hear this time and again. There's not enough staff. I don't have enough time. So limited resources, both human and equipment. So we built that in. That's a problem. There's lots of demands on nurses in the United States. Once we did the observation studies, I started counting how many times that nurse was interrupted in their process of care, and it was amazing. It was amazing. Like, it was, to me, it was marveled that they could even get that medication passed without somebody else interrupting them. So there's always a break in their process of what they're doing. So increased time demands. Opportunities became an issue. Patients have to go off for tests, and so we schedule them multiple procedures throughout the day, which we need to because of their diagnosis, so we limit the opportunity for them to get up and to move around, if you think about those. We found that there was really a poor mechanism to communicate this task of patient ambulation. So that should be so easy, but how we communicate it to each other, to healthcare providers, not only nurses to certified nursing assistants, but with physical therapy and our colleagues in medicine, and to patients, that this is important for you to walk, and here's why it's important for you to walk, was a problem. And then there was this culture that we now know, it's actually low priority to ambulate patients because they might fall down, and we don't want falls. So if they're walking, they might fall, and we have to have 0 falls in our systems. So we actually found that the message of 0 falls, what nurses interpreted that is, if I'm going to get dinged because my patient fell, my patient's not going to fall, my patient's not moving. So they restrict movement for a reason, and it's to control fall rate. So we are looking at the wrong thing as far as a quality indicator when it comes to falls. That is the most efficient way to decrease your fall rate, is just don't let somebody move. So then we found that there were barriers to limiting patient engagement. Patients are restricted because we don't want them to fall. We contain them to a better chair. We put all their possessions next to them. They really don't have to move. And patients actually sense that the nursing staff is way too busy and they don't want to bother them. So they won't ask, can you get me up and walk me? They're afraid to do that. So it's a problem from a patient. How do we get patients engaged with movement? And then there were personal barriers that prevented nurses. So nurses think 2 things. You're going to fall, and you're going to get injured, and that's a problem. Or I'm going to injure my back, and that's a problem. So there's this perceived risk for injury that's a big issue with nurses, and that will stop them dead in their tracks before they engage patients in ambulation. The other thing that we found is that we think nurses should be able to do this. We don't teach them really how to do this in our nursing schools here in the United States. And they have little opportunity to practice it because we're not moving patients in hospitals, so we send them out of UW-Madison, and we send them out to whatever hospital, and we think they're ready, right? They should be able to know how to do it. They don't know how to do this. They don't know how to do an mobility assessment, and they sure don't know how to get a patient up on a ventilator with 3 drips and 2 tubes. They don't know how to do it. So there was a significant decrease in self-efficacy in nurses' ability to actually engage patients in movement. We think they should do it. And I was talking to a colleague who says, back when I was a nurse, and I keep saying back when I graduated from undergraduate, it's what we did. We didn't have physical therapy up on the floor. So we did it. Well, now we have PT up on the floor. So who does it? PT does it. So we have taken off this opportunity for nurses to become comfortable in ambulation. So we came up with MOVE-IN. This is MOVE-IN. So we thought, okay, so where are all these things? We started putting them together in the SEIPS model. So we thought, we got to train people. We got to train these nurses on how to do a mobility assessment and get them walking these really sick patients. So we had them go with physical therapy. They did hands-on, direct training with PT, in doing a mobility assessment, getting feedback constantly from the PT. This is how you're going to do it. And now let's walk patients that are scary, really scary to walk. They were now doing it. Then we thought, well, if you look at ambulation pathways, we don't know how far patients walk. That was the problem. So we wanted to build in distance markers in the hallway. So now we can accurately measure how far patients are walking. And we put artwork up in the halls to make it more appealing and interesting for patients for walking. We developed a communication mechanism, so we put all of these activity whiteboards in the patient's room. So now there's communication with the patient, with the family, with the nurse, with the physician, with the physical therapist. Anybody that walks in the room can look at that whiteboard and say, oh, you need assistive once, you need a gait belt, you need a walker, and no, you walked 500 feet. Going to the bathroom? No problem. Let's get you moving. So it changed what was happening on the units. We looked at resources. We put an ambulation aid in place, but we were very strategic over what hours that ambulation aid needed to be because we wanted to maximize opportunity. We made sure walkers were available on the unit so that they didn't have to wait an hour or 2 hours for it to come up from central supply. It was ready to roll. We can move. And then we worked really hard on organizational culture. How do we make this a priority on these units? And that really took a lot of investment with our partner on how do we create culture change on ambulation on the unit. We wanted to improve patient ambulation, and these are our outcomes are down the line. How do we look at, do we have less hospital-associated disabilities? Are they less likely to, do we decrease length of stay and readmission, and then do patients feel better about it?
How did you change the culture?
We worked really hard at this. So we worked hard on culture change. So we did a couple of different things. We celebrated with that unit over and over and over again. So we hit goals. We had goals for every time that they hit a goal. We did a celebration. We did a great big posting in their break room. And so we had like a running track. We had a little patient with a walker. And we put achievement in miles. So it wasn't feet. It was your patient has walked, you have walked patients 5 miles this week. And we looked at accumulating miles. And we were trying to get them from Wisconsin to Illinois. And so when they crossed the Illinois border, we had Chicago-style pizza, not because we were in Chicago. We didn't care. They were in Illinois. We were celebrating. Nurses would tell us over and over again, the incentives were nice, the weekly drawings, the celebrations, but knowing what they were accomplishing was huge for them. Knowing that they were making this much of an impact on their patients was huge for them. So great way to incentivize. How do we build impact? What is it that nurses want to get at? They want a good thing for patients. They know they want to improve these outcomes. This is a great way to do it. We also gave them patient feedback. We posted it on the bulletin boards. What were patients saying about what they were doing? So they were getting immediate feedback all the time about their efforts and how their efforts were improving patient perception and outcomes. We had senior management and mid-level management coming up during these celebration events, showing their support. And the fact that we got the hospital to pay nurses to participate in the psychomotor skills training was a huge message to them that this was important. And the fact that they were not being pulled from training was another huge message that this was important and supported by the organization. So those are some of the things that we worked with for culture, shifting the culture.
It seems like this should also be something that would be, I mean, I think your figure at the beginning of this presentation was $26 billion a year. That's a staggering figure. It seems like this would be something that would be really easy to create a mandate from above for if you figure out where that cost is going to, and I'm sure you might have actually already done this, to figure out who's actually paying for that cost. And if you find those people, and it would be also really important in the low resource settings that Dan was talking about a second ago, where they don't have, which is where a lot of these hospitals are, and where they don't have a lot of nurses, they can't add bodies. Identifying who is actually bearing that cost and going to these people, and similar to something that we heard earlier today, there was an analogy about choosing whether or not to vaccinate your child or wear a seatbelt. And you tell these people, look, you can choose to have your nurses focus on ambulating these patients, and if you don't ambulate them, this is where it's going to come back to bite you. Now the decision is yours to try to put this into your system. It seems like with that kind of monetary figure, especially in a low resource setting, kind of intervention.
Yeah, I want CMS to reimburse hospitals for walking patients.
It seems like that would
That's
be.
That's what I think. You should reimburse us for walking patients instead of we're going to penalize you for patient falls.
Yeah, I mean, if you, I would think if you could prove the cost benefit of the ambulation.
And that hasn't been done yet, so we haven't looked at that.
So we're just going to scroll through a couple of these, and again, some of these slides are pretty straightforward. Part of the culture was we did have a very diverse and integrated team, so we worked very closely with the unit throughout this process. Before we started, as we were designing the elements of STRIDE, we had staff members and leadership on our team And then we had a lot of people, way more than we expected in the organization, that wound up being engaged in this project and therefore became stakeholders and supportive. And again, that message carried through to the unit, and they felt like this is something that we take pride in at this point. Oh. And then this was a research pilot study initially. Certainly we're aiming at quality improvement, but it was a research to see if this intervention might work. So we did have a research design, which again would fit with many quality improvement projects, where we had baseline data that we collected on how nurses were communicating about ambulation, what was being documented about ambulation, what were their perceptions. We had accelerometers on patients for how much are they actually moving, sort of more objective data, and then patient interviews. Then we implemented our different components that Barb had described, and then did some post-measurement on the same types of measures as well. So we have a mixture of quantitative data from an EHR, we have qualitative data from interviews, we had surveys, we have this accelerometer data, so we can pick up very small changes in gait and functional changes there. We haven't analyzed all that yet, but we have it. Some of the pictures. So again, a lot of these actually do relate to culture. There was a lot of visibility for the program. We had lapel pins. We had little arm bracelets. We had posters. We had giveaways. We had food. That was a big incentive for our staff. We had this My Activity Plan. This was the sort of template on the whiteboards in the patient rooms. And again, we heard that was, we didn't necessarily know what that was going to mean, but it was very effective as a communication mechanism, more so than the electronic health record. And we got a grant to have artwork to try to have this walk around Wisconsin theme to add, which for those of you in low resources, we heard that was not as critical. So you can cut the artwork. It's a nice bonus, but not as critical.
The unit liked it. Patients didn't even recognize it and pay attention.
So what we were doing was a feasibility study to show that this type of multifaceted sort of system intervention could work, and we could get nurses trained. We could do this all at one time. We could recruit patients, and what we found was that we could. We did this on one unit at our hospital across the street. We wanted to recruit 10 nurses out of their roughly 30 that were on their staff, and 20 of them, we had to add more training sessions because we had much more interest than we anticipated. This is too much to digest today, but overall, we did see significant differences between the pre-intervention phase and the intervention phase in terms of the distance that patients ambulated, so that's huge, both in feet and miles. If you look, we have our pre-phase. This was data we got from beforehand, then during our intervention, and then some post-data that we're continuing to collect to look for sustainability, because we wrapped this up in June. So far, we haven't seen a drop-off, so that's good. So distance, the occurrences or the frequency of ambulation, getting patients up at all. And then we looked at documentation, because this was important for a lot of what we heard for the feedback for maintaining the culture was this constant awareness of we are making progress, we are moving patients, this is how much we're moving, and having that data available to the staff was important. And so if all the documentation is qualitative, like up to chair or up to bed, it's hard to get those data. So we really emphasized the actual distances using the markers, and we saw a huge increase in the percent of numeric documentation on how far patients were walking. Yeah?
So, in a low resource setting, I mean, this is a high resource setting, lots of money,
Yeah.
put it in, do it. We have a lot of low resource settings. What would you recommend as a first, second, and third step to increase ambulation in an institution with limited resources? How would you document that? I mean, they don't care about, you may not care about the epic electronic medical record, but you care about what would the most important take from this?
So I think probably it's really important from a communication standpoint is the awareness that patients are progressing, because that stimulates nurses. Oh, they're getting better. This is great. So, but if you don't know that they're progressing because you don't know the distance that they're walking, that becomes an issue. So having a mechanism to communicate that's really important. I think changing the culture is huge, and that can be a battle. I mean, you have to make sure that they're talking about it during each shift to shift report. How part of the patient's walk? How well did that patient tolerate it? What's our plan? So generating a plan, engaging the patient is really critical, and the family. So that whole communication piece of it blends with unit culture, so that becomes pretty important to establish.
So, you know, you might do it just thinking for a second. You just get a cheap, inexpensive pedometer. You count the number of steps around, because those are inexpensive and put it on the page and then count the number of steps and put that on the chart.
You know, we found that if the nurses didn't mark it on the whiteboard, the patient said, hey, what's not my whiteboard? I want credit for that. Put it up there. And it was now became a feedback mechanism with the patients. So that communication and how do you establish this is what our standard is here. And how do you make sure that patient understands that this is our standard here, and you have a goal, you actually have a little work to do while you're in the hospital. So here's the goal, and how do we set up the goal? So that whole communication and culture shift is pretty critical. So if you don't do that, that's going to be a problem, changing what happens within your institution.
But the pedometer that we have thrown that idea, like let's just get a Fitbit or pedometer or whatever on and have them available. Yeah, pedometers are much cheaper, but you know we want our nurses to actually wear Fitbits, but for another reason.
It's a feedback mechanism for patients, and that's
it's engaging.
Important.
It works for us to get our 10,000 steps. So
right. I'm always looking at my phone. Oh shoot, I gotta get 2,000 more steps in today. So
yeah.
Yeah, I just want to comment on in so many. I think it's easy because some of the details are, you know, more expensive, or you're measuring a higher resource setting. But some of the interventions are really simple and are very much in line with what are feasible in the low resource setting. It doesn't have to be a whiteboard. It can be a piece of paper. And you know, these simple job aids, they actually make the room look more pleasant. You know, even when there's guidance on the walls and so forth. And so a lot of things. And I think too, when people aren't aware that they should be walking, people are spending time. It's already dead time with someone who really cares.
Yeah.
You know, a family member is sitting there not knowing that they should be walking. So to me, that's not a resource issue. That's just
visibility.
Chat with information because their intentions are even better than ours. You know, they've got a life commitment. So I think there is a lot of potential here, and it's you know, it's one of the few things we'll talk about infection control tomorrow, but this is just so cross-cutting for these settings.
And the other thing to think about is we have to make sure that your workers are trained in order to do this. So they really don't know how to do this. We need to give them some skills. So we got to think about how do we give people skills and knowledge, and how do you actually do this? Train your CNAs. It doesn't have to be an RN. Just make sure that they are equipped with the skills they need to do the task. That becomes an issue.
And I would say that so often we're sending health science students to clinical settings to observe. They're not their first years. They're not ready to do a bunch of things. If they are trained properly here, like at the CNA level here, this is something that a shadowing student can be useful. They can train family members in how to do this. I mean, I know you have to make sure they know what they're doing, but it shouldn't be that hard if they're a first year health science student here.
Well, Becky Cordell over at the VA, if you're a medical student, you want to go there, she makes them all walk patients. Not an option. They're coming in her system, they will walk patients. So they get training on, how do I determine activity? Rather than saying, I'll just put up ad lib. For nurses, up ad lib, it gets interpreted all kinds of different ways. So it's actually not very effective to put that down. Yeah. Questions? Other thoughts?
There's two. Yeah, no, well, we're in break time now, so we want to be respectful of that. But it looks like we have two questions, and then we'll just tell you what's in the rest of the slide. We won't go through them, but so you can look through. They're pretty, I think, followable on your own. That's not a word.
I'm Laura. I work as a CNA out there in the hospital, and I'd say encouraging your students to get people up. We want to know people after you guys are really good at it. And I bundle my walks. I with my eating here, so I'll say, let's get up, let's brush teeth, and then go for a walk. And it's so time efficient, and if you can do that too, like if you're in other zone up to go to the bathroom and brush your teeth, you're already almost out the door. So then just encourage you to take a walk down the hall.
Yeah.
I'm working on an infection control project, especially for patients under enhanced contact precautions for students. Do you notice a difference of what happens with that when they're in the hallway. They walk around less than patients who are not under.
They are contained in their room, but we're finding, well, when we did the study, there are patients with C. diff, you double gown them, guess what? You're going out. And they're letting them out of the room to get them out in the hallway to walk them and then bringing them back in. So we had to put gloves on them and 2 gowns, and we put gloves on them and 2 gowns, but they are going to get out.
Is there like a specified procedure in place for patients who are under contact precautions for them?
So there are no, first of all, there are no standards about how often to walk patients. They don't exist.
But like for
In
patients
general.
coming out of the
So
room.
we really don't know about patients that are in isolation. We don't know. And so good question. I mean, again, is it another barrier that particular patient population? We let them go out for procedures all over the hospital. So is there ways that, have we increased infection rate if we let that happen? We don't know. We don't know.
So the last few slides just have some of the quotes that you all can read that we got from our qualitative data. And again, we saw a lot of themes about culture, visibility, like the transparency of, now I know this is an issue, I have the training, and then the data is coming in. So whether it's from a pedometer or it's from an EHR, it's on a whiteboard, it's on a piece of paper, that feedback loop was critical. Again, diverse staff, not just those on the unit, were giving us feedback that was unsolicited. And I think we've kind of hit most of these. It took an interprofessional team. It was very complex to plan this, lots of coordination. In the future, we need to think about how to better engage the patient and the family, which would be very critical in some other countries and may be the solution. And then there is the potential for, we have to be aware of these external influences, like quality can go bad. That's sort of my phrase, but some of the messaging that's coming externally about falls and avoiding falls is a barrier, and that is a challenging one to overcome. That's why for us, having that senior leadership buy-in was critical for making this as successful as it was on this unit. We have some resources for those of you that are interested in mobility that Barb put together on some of the common measures that you might look at if you want to start to track this in your organization. And then a number of additional readings if you want to look further at systems, human factors, and then, again, mobility data. And our contact info. So we're in your break. We need to stop, but we'll be here for a few minutes, or feel free to email us or contact us anytime.